And now I have the pleasure to introduce our next speaker, John Coetzee. He's a postdoctoral researcher at the Stanford Medicine Brain Stimulation Lab, and today he will be presenting on heart-brain coupling and how it can be leveraged to investigate iTBS target engagement, clinical stimulation effectiveness, and of course, cortical excitability.
Okay, thank you everyone. Good morning. Excited to be giving this talk to you. It's sort of a slightly different way of approaching the topic of cortical excitability. Sorry, I'm just getting familiar with this. Okay, I see it. Okay, so how do you advance? So no conflicts to report. Okay, so transcranial and magnetic stimulation has been shown to be an effective treatment for depression. And it's become widely used in several countries for treatment-resistant depression in particular. The sort of typical or conventional version of TMS is 10 hertz TMS, where you get it 20 minutes a day, once a day for 6 weeks. And the response rates there tend to be around like 50%. And there are new protocols that have been developed where there are newer accelerated protocols where it's delivered 10 times a day for 5 days and theta burst, and there the remission rates get as high as 80 or 90%. So TMS is becoming a very promising method for treating treatment-resistant depression. But there are some drawbacks that are relevant to the topic of the panel today. So the first one is, so the most effective forms of TMS, like the one I mentioned earlier, the accelerated versions, such as there's something called SAINT, which is an accelerated version of TMS, which involves personalized targeting in an MRI. And then you neuronavigate to the target using like a Localite or a rogue research system. And MRIs are, of course, very expensive. They're not easy to access in all countries, and it seems like you need a relatively sophisticated MRI to get the kind of targeting you need for that approach. And then the second problem is with establishing the right dosage. So, if we're going to personalize targeting, we want to personalize dosage as well. But to date, TMS typically relies on motor thresholding, which was explained extremely well in the previous talk, so I won't spend a lot of time talking about it, other than to remind you that, as the previous talk pointed out, there's a lot of variability and responsiveness to TMS in different parts of the brain, depending on what you're stimulating. And if you're trying to treat depression, then usually the target is actually not in motor cortex. The therapeutic target is not in motor cortex at all, but it's in the frontal cortex, usually the left DLPFC, especially a location in left DLPFC that is functionally anti-correlated with a subcortical target of interest. And so the idea that frontal cortex is going to have the same cortical excitability as the part of the motor cortex responsible for the hand is a kind of a dubious proposition. So one possible solution that a few labs have been pursuing is this idea of having a different readout for target engagement when you're conducting therapeutic TMS for depression. And so some researchers have found that when you're stimulating DLPFC for depression, that there tends to be, during the treatment, a simultaneous change in heart rate. which seems to involve immediate deceleration of the heart. And the thinking here is that there may be a direct anatomical connection from DLPFC through subgenual ACC to the descending arm of the vagus nerve, which is then causing the heart to decelerate when you target DLPFC. And so the thinking is that if this could serve as a different way of thresholding your stimulus, it could potentially be more relevant than motor thresholding at the hand or the leg or anywhere in motor cortex, because this is typically in the part of cortex that you're targeting for depression anyway. And you can get sort of immediate feedback on how much deceleration you're causing. You can do like a ramped approach where you're trying a series of intensities, much as you would with motor thresholding of the hand, except instead of the hand, the readout is going to be changes in heart rate. But I should mention that this is still a bit controversial, this circuit. We submitted a paper related to this like a year ago, and the reviewers were very concerned that maybe this change in heart rate is just a result of like a startle reflex or pain or something like that. So this is still kind of something that we're making the case for. So this is an illustration from a recent paper that was analyzing some data related to this. So you can see, let's see if I can move the mouse. Oh, there it is. Okay. So you can see that during each, so on the top here, it's the conventional 10 hertz rTMS. And let's see. So you can see that during each pulse train, there's detectable heart rate deceleration. And what we found is that a measure that seems to be more consistent and more robust is actually something that extends across the whole sequence of pulses, which is a ratio of the periods of deceleration to acceleration, because it seems to bounce back to the normal heart rate between trains. And so that ratio gives us something that we can call the heart-brain coupling factor, which is a ratio of how much the heart is decelerating relative to how much it's accelerating during the train. And that seems to be more robust than just looking at the amount of deceleration itself. And so this ratio depends on the amount of time. It's kind of like a duty cycle. It depends on the amount of time that people are spending in a pulse train versus not in a pulse train. So for conventional rTMS, that value is going to tend towards 0.0625 hertz. But for intermittent theta burst, which is what you have with some of the accelerated versions of TMS, it's going to tend towards 0.1 hertz. Okay, so we analyzed some data from a trial. It was like a blinded trial of an accelerated TMS protocol. It was the SAINT blinded trial. And so we had a couple of hypotheses we wanted to test here. The first was that the heart-brain coupling factor would be significantly higher among active than sham participants in the SAINT RCT. That the mean heart-brain coupling factor would be predictive of treatment response, and that the mean heart-brain coupling factor would be predictive of subgenual anterior cingulate functional connectivity changes. This is the device we typically use to record heart rate. So for this kind of thing, ECG is usually what you really want to have. It seems to be more reliable than like an infrared light on your finger or a wearable or an Apple Watch. You really want something picking up like electrical signals from the heart. And this device is made to be used with TMS in that it will timestamp the data with the TMS pulses, which helps with this kind of analysis. So it's put out by Neurocare. It's a NCG device. Okay, so we started off with 20-something participants. After quality checking the data, 17 remained, and then there were 3 that didn't have enough usable data, and so we were left with 7 active, 7 sham. And I want to stress this is like really just a pilot, because this is a small number of participants. We expect to have a larger number of participants soon. There'll be a similar study with like 100 participants finishing next year, and so that's when we get to validate some of these approaches. Okay, so we conducted a linear mixed effects model on the heart rate data. And there's 2 steps to the QC. The first is like having people eyeball the data. The second is that the script we're using, which is a script developed by brain clinics, that also has its own internal filtering. And so we had so group number here refers to active or sham. And so we had a significant effect of group membership, but not of gender, age, treatment day, treatment session, or an interaction. So this was effectively telling us whether they were in active or sham. And then we looked at some correlations for the entire group, and we were looking at the HBC factor as well as the percent of HBC factor values above a cutoff of 2, which we found seemed to be a reliable number for telling us whether they were in the active or sham group. Let's see. Okay, so I apologize for the acronyms. So the PRFB just refers to the percent reduction from baseline. So we're trying to relate the heart-brain coupling factor to clinical outcomes following treatment. So the HAM-D6 is a common depression measure, and the MADRS is as well. And so for the mean heart rate coupling factor, so this is just going to be the mean across all of their treatment sessions. And so each individual is getting 50 treatment sessions because it's 10 times a day for 5 days. So it's the mean heart-brain coupling factor across all the treatment sessions. And then we also have the percent of those that were greater than the threshold of 2. So the amount their depression score went down by week 1, which is like immediately after treatment, was predicted by, or sorry, shouldn't say predicted, was correlated with their heart-brain coupling factor and with the percent above 2. Same for the HAM-D6 at week 4, which is like 3 weeks after treatment, and same for week 5. And actually, it's more highly significant and a stronger correlation at week 5, which is 1 month after the treatment. So it seems like it may be predicting some sort of delayed effect of the treatment. Just very speculative right now, because as I said, it's pilot data. And similar results, similar correlations for the MADRS, and also a correlation with chronological age, which we're not sure what to make of yet. Okay, so the previous slide was looking at the entire group, and I want to mention that one thing that's a bit of a confound is that since this measure discriminates between active and sham, some of the clinical outcomes could just be a matter of, the clinical correlations could just be a matter of telling us who's in active and who's in sham. We don't really have enough data to get a solid sense of like within each group yet, because we only have 7 active and 7 sham in this analysis, but just as a very preliminary result, it seems like there was a significant correlation with the percent reduction from baseline for the HAM-D6 at week 5 at the 1 month point, and also for the mean percent reduction from baseline across all the post-treatment time points. Okay, I know I'm running a bit over time. Okay, so this is just a scatter plot of percent reduction from baseline on the HAM-D6 at the 1 month time point, and that's on the left axis. Whoa. And then on the y-axis, I mean, and on the x-axis is the mean heart-brain coupling factor across all time points. And they're color-coded by group number, whether blue is sham and 1 is active. And it seems like this effect is being driven by these 3 down here, who have a relatively large relationship between their heart-brain coupling factor and their reduction from baseline. And it seems like they're separating out into 2 distinct groups. But as I mentioned earlier, we need more data to validate this approach. Let's see, I'm going to skip this in the interest of time. So this is just looking at mean heart-brain coupling factor between the groups. And I'll just skim this very briefly, that in some very preliminary analysis, we have been finding that the heart-brain coupling factor is related to the amount of functional connectivity between the subgenual ACC. Let's see. Okay. That higher heart-brain coupling factor seems to be related to lower functional connectivity coupling between subgenual ACC and pregenual ACC at baseline. So we're continuing to explore this data, but it seems like there is some kind of relationship there, or maybe some kind of relationship there. This is still very preliminary. Okay, and we mapped it onto the same graph we saw earlier, and patients with the strongest heart-brain coupling factor, those 3 at the bottom that we looked at earlier, had the highest anti-correlation between subgenual ACC and the left ACC, and the highest percent reduction from baseline post S&T. So some kind of relationship going on there. Okay, and in the interest of time, okay, just to kind of relate this to cortical excitability, heart-brain coupling factor can potentially be used as a real-time readout of cortical excitability without an MRI, and by stimulating the left DLPFC in a stepwise fashion during ECG, we can determine personalized optimal coil intensity. And we've recently applied for an R21 to use interleaved TMS fMRI to validate this approach. And yeah, so I'll just skip that to the acknowledgements. And thank you very much for your attention, and happy to answer questions here. And I'll also be around at the posters later if people want to ask me questions there as well. Okay, thank you.
Okay, thank you so much, John. This was a very interesting talk. In the interest of time, I will just ask you one quick question from the audience. Yes, please. Did you already adjust TMS dosage using heart rate deceleration for the last study, as you advertised in the beginning?
So the question was whether we adjusted TMS dosage based on heart rate. No, that's an approach that we're trying to develop. So the way that dosage was determined in that study was they did motor thresholding, and they did using the hand as typical, and then they did a Stokes adjustment where they adjusted for cortical atrophy, cortical distance from the scalp, and then everyone was stimulated at 90% of motor threshold with that Stokes correction. And so we're trying to look after the fact to see if there's a relationship between how much heart-brain coupling people were experiencing and how much clinical effect they were getting. And we want to develop heart rate as an approach for determining dose, but that wasn't how it was determined in that study.
Thank you very much, John. Okay, then we will go on with our next speaker.